Now let's talk about the anti-ethmoidal artery. Okay. You see in the orbit, you see this, right? This is the medial rectus and this is the superior rectus. And this complex of the medial rectus and superior rectus is where the anti-ethmoidal artery is. There's this beaking over here. It's called Kennedy's nipple. There's a beaking over here, and this beaking is what which causes the anti-ethmoidal. So this is the orbitocranial canal. This is where the anti-ethmoidal artery is going from the orbit to intracranially. This is what we saw on the in the osteology lecture. We talked about it. Okay, so this is the anti-ethmoidal artery going from the orbit intracranially. Okay, so the orbitocranial canal, and this is lying in the skull base. Now, as opposed to that, this anti-ethmoidal artery is at the same place, the complex. This anti-ethmoidal artery is lying exposed. So in our mind, what we think when we say exposed is we think that it is lying low, it has a misentry. But if you look at this, see this, where is this anti-ethmoidal artery entering the brain? At the apex of the lateral lamella. This is the middle turbinate here. This is the middle turbinate. That's the horizontal lamella. That's the vertical lamella. And there, at the apex of that vertical lamella is where the anti-ethmoidal artery is entering intracranially. Now look at this. Can you see here? That's the horizontal lamella. That's the vertical lamella, and it is entering at the apex there. So the artery is exactly in the same place. It doesn't come down. It's not low. What has happened is not the artery has come down, it's the nose which has grown up. Which means what has happened is when there is a supraorbital cell, pneumatization of the skull base and the supraorbital cell exposes the artery. So therefore the artery lies at the same place, but the supraorbital cell exposes it. Therefore, the important thing to remember is that when you see an exposed anti-ethmoidal artery, there will always be a supraorbital cell. You can't have an exposed anti-ethmoidal artery without a supraorbital cell. If you look up, there's a journal, the American Journal of Radiology, if you look up anti-ethmoidal artery and Bradu, you'll find that article that we have written. Either Bradu or Joshi and anti-ethmoidal artery, you should find that article where we have written about this, that the anti-ethmoidal artery is always exposed only when there is a supraorbital cell present. Does it make logical sense?
Yes, ma'am.
Any questions on this? Okay. Now, it's very important to have sagittal sections, okay? For one of the most important things about a sagittal section is to be able to measure this distance from the cribriform plate to the frontal beak. Now, you see this frontal beak, it's pneumatized. Okay, so there is a agar cell, and there are in other sequences you would probably see more cells. What you can see in the thing is, first of all, you can see the middle turbinate is pneumatized, and then this is the ground lamella. This is the agar cell. This is a pneumatized and uncinate process. This is the bulla. That's the suprabullar recess. This is the ground lamella. And beyond the ground lamella, this is the superior turbinate, the posterior ethmoid cells, and this is the sphenoid sinus. And you can see how the skull base slopes downwards like this, okay? Here also you can see that's the middle turbinate and that's the ground lamella. That's the uncinate. This is a possibly type 2 frontal cell. This is the uncinate. This is the anterior wall of the bulla. This is the ground lamella. This is the posterior wall of the bulla. And between the two, there is the retrobullar recess over here, as you can see. Beyond the ground lamella is the posterior ethmoid cells. That's the superior turbinate. This is the anterior wall of the sphenoid sinus and the sphenoid ostium. So all these things can be seen on a sagittal section. And when you're doing complex frontal surgery, or if you're doing a revision frontal, you must have sagittal sections which are 1 millimeter cuts. So you can study that frontal recess very well, how many cells there are, how big they are, how much is the distance between the frontal beak and the cribriform plate. All this you will discuss, or you will see on sagittal sections. The attachment of the uncinate process you will see on coronals. The supraorbital cell you will see on all three, axials, coronals and sagittals. Okay. The anti-ethmoidal artery you will see better on coronals. Okay. This is what is a frontal bulla cell. So you see, it's different from the supraorbital cell. This is lying within the frontal sinus. Can you see that? I'll show you that again so you can understand the difference between a frontal bulla cell and the supraorbital cell. Can you see this? This is the frontal sinus, and this cell is lying outside. There's a partition, and then it's beyond the frontal sinus. That's a supraorbital cell. Whereas, if you see this is a cell lying within the frontal sinus. So is that clear? So you have the agar cell, then you have the frontal cells, which are all those different types we talked about along the anterior wall of the thing, frontal beak, along the posterior wall. So you have the agar, supra-agar, frontal, bulla, supra-bulla, and then beyond that is the supraorbital cell. So that is the sequence you're following. Agar, then uncinate, or agar and frontal cells, and then beyond the frontal cell and frontal sinus is supraorbital. Okay, all this that we discussed was about the anatomy. So all this I said, the first thing I said, the first challenge is variable and precarious anatomy. So this is what we've discussed so far. In 45 minutes we have just discussed the anatomy, okay? And then now the second challenge we're talking about is hand-eye coordination. Someone has written that, I want to be proficient with using a 70-degree telescope. So hand-eye coordination is the issue. Now why is hand-eye coordination an issue? See, when you're putting an instrument into the nose, your hand is moving in the x-axis. Your instrument opening is also in the x-axis. And your scope is also visualizing in the x-axis. So something like this. That's the scope and that's the instrument. But when you use angled instruments, then what you're doing is your hand is moving in the x-axis, but your scope is looking in the y-axis and your instrument is operating in the y-axis. So though your movement of the hand is this way, the movement of the instrument is in the y-axis, and because of this difference in axis between the x and y-axis, that's why you have a difficulty in hand-eye coordination. Where do you keep the scope? So first of all, when you're operating, we know that the skull base slopes like that, okay? It slopes. So therefore, you always keep the head semi-flexed. In FES surgery, you keep the head semi-flexed, which means that the orbitomeatal line is called Reed's baseline, R-E-I-D, Reed's baseline, that is from the lateral canthus to the external auditory meatus, the upper border of the external auditory meatus. This Reed's baseline, which is like this, should be at right angles to the plane of the table. So this line has to be right angles to the plane of the table. That is the semi-flexed position in which you operate. The reason you do that is that as you put your instruments through like this, you are running parallel to the skull base. You're not directing it towards the skull base. But when you do frontal sinus, when you're operating in the frontal recess, for that portion of the surgery, you extend the head. Okay, so what happens is, if you do the rest of the surgery like this, you'll damage the skull base. But for the frontal sinus, when you extend the head, your trajectory of the scope is more towards the frontal sinus. Your instruments are also moving more towards the frontal sinus in that trajectory. So you will be able to use a 0-degree endoscope and straight instruments for a longer period of time before you shift to angle scopes. Okay? But after you found the frontal sinus, then you reflex the head. You put the head back. You flex the head again, so that the rest of the surgery, anti-ethmoidectomy, posterior sphenoid, is all done with a semi-flexed head. Only the frontal sinus, for the frontal sinus, you will extend the head. Okay? How do you use the scopes? So when you're using a 0-degree scope, it will be above and the instrument will be below. The scope will be at the apex of the nasal area, and you will pull the nasal area up with the scope so that you get more space, and then the instrument will go from below. In case of a 70-degree telescope, the telescope will be below and the instrument will be above. Now the problem with this is that yes, you'll be able to introduce the instrument properly, But what happens is with the telescope below and the instrument above, you can see only the tip of the instrument. You can't see the shank of them. So it can be disorienting. So ideally you should keep them side by side. So keep the 70-degree telescope near the septum or near the lateral wall, depending on whether you are right or left side, and the instrument will go along the side of that. So that is a better way of doing it. In the 0-degree scope above, instruments below. But in a 70-degree or a 45-degree, scope on one side, and from the side of it you put the instrument. Now we come to something which is called uncapping the egg. Stamber came up with a brilliant concept that is called uncapping the egg. Now, in Europe, they eat eggs, half-boiled eggs, and they use them in an egg cup. So there's an egg cup, and in this egg cup you put an egg, and then you open it, and with a spoon you eat up that half-boiled egg. Now suppose you take this egg and this egg cap, and you turn it upside down. Then what you have is the frontal sinus, the frontal ostium, the frontal recess, and an egg sitting in that frontal recess. Okay. Where is the outflow tract? This narrow thing. The frontal sinus is draining through this. Okay. So it's a very narrow space. It's almost a potential space between this egg and the egg cup. So the egg cup is the walls of the frontal recess, and the egg sitting this may be any cell, any cell. So the cells narrow off this frontal outflow tract, and so what you have to do is you have to remove this egg which is there, so that the frontal outflow tract is revealed, is opened up. You're not, see, in maxi-sinus ostium you're creating a wide ostium. In sphenoid sinus ostium you're creating a wide ostium. Here the frontal recess is already there, but you're removing everything within the frontal recess so that the frontal recess is seen. Have you understood the difference in the concept we are talking about? So what is this egg in this frontal recess? So what is this eggshell? It can be the upper part of the uncinate. It can be the upper part of the agar nasi cell. It can be the upper part of any frontal cell, like this. Okay? So the thing is that you need to remove these eggs. Now let me give you the psyche of a young surgeon. Okay, you think that okay, on one side is the orbit and the other side is the brain. I'm operating between the two. If I stay close to the middle turbinate and if I go through this lateral lamella, I'll cause a CSF leak. If I cause a CSF leak, I have to repair it, which means I'll have to take some extra tissue. And after I repair it, not only do I have to tell the patient, of course you'll always tell the patient that you've had a leak, but now I'll have to keep the patient in for 5 days instead of 2 days. I told him that you'll go home after 2 days. Now I'll have to keep for 5 to 7 days till that repair leak heals. So the complication is going to significantly impact morbidity and how the his bill will go up from 2 days to 5 days. Whereas if I open the orbit, if I stay away from the middle turbinate and I stay close to the orbit, if I open the orbital fat, all I have to do is tell the patient, don't blow your nose hard, and he can go home on the second day. So the tendency is to stay away from the middle turbinate. Okay, don't go very close to the middle turbinate because you can cause a CSF leak. Now what is the correct way of doing it? The correct way of removing these cells is with either a frontal curette or with a Kuhn's probe. Okay, and the correct way is to go close to the middle turbinate but direct the instrument laterally and then pull out the cell. So first you would go from here, pull out this cell, then you'll go from here and pull out this cell. Is that understood? That is the way you would do it. Why do you stay close to the middle turbinate? Because if you don't do, and if you stay close to the orbit, this is what will happen. You will go through the cells. You will go through the cells into the frontal sinus. You will see the frontal sinus. You will see the glow of the frontal sinus, but the outflow tract will still remain narrow. Now let's go back so that you can understand that a little better, and that is this. If I want to enter this area, I can either remove this egg and then there's a wide frontal recess and I can enter this, or I can go through this egg, through the roof of that egg and into the frontal sinus. And I'll still see the frontal sinus, but that outflow tract will remain narrow. So it is necessary that each cell be removed, and therefore one is on CT scan, you'll see the cells, and second, endoscopically you will keep removing the cells layer by layer, from staying close to the middle turbinate but directing the instrument laterally and anteriorly. So this is not the way to do it, okay? Because at the end of it all, you see the front, but you'll see a whole lot of septae cells, and this outflow tract will remain narrow. Okay. This is how you should do it. So you see there's this eggshell, it may be the upper part of the answer, it may be upper part of the agonist, but see how close the ball point is towards the middle turbinate and how it is directed anti and laterally. Can you see how close to the middle turbinate, but it's pointing laterally, and you remove the cell like this, anterolateral direction. Okay. Now, when you use a suction in the frontal recess, there are very specific things that you have to remember. First of all, use a narrow suction. Okay, never use a broad suction, because a broad suction can crack the lamella of the lateral lamella of the turbinate and cause a CSF leak. So be careful that you use a narrow suction. The second thing you do is, you take the tubing of the suction, just look up. You take a tubing of the suction and you place it here. Don't hold it. And you place it here and you place it near the face of the patient, and it should take that suction, take the direction of where you want to go. If the suction is pointing in any other direction, and if you use the tube and move it like that to go into the front, when you release it slightly, that suction will move inside the frontal recess, and you can cause a leak like that. So always place the tube here without holding it and see that the suction is actually taking the direction that you want. And the third thing to remember is something which we call targeted suctioning. We call it is not actually called, I think of it as targeted suctioning. And that is that if it's a narrow frontal recess and you want to suck inside the frontal sinus, don't go in with the suction open. Because if you go in with the suction open, it will pull on the suction on the mucosa, suck in the mucosa and abrade it as it goes. So what you do is you close the suction, you put the suction into the frontal sinus, and then as you are withdrawing the suction, you open up the suction and suck. Do you understand? It's similar to if you're sucking around a CSF leak repair, you will first keep the suction closed, go where you want, open the suction and suck over it. So also that's why target, yes. Always there's a double angle suction. The frontal suction is always double angle. It's a separate type of suction. It's not the maxi suction, it's not the straight suction, it's a double angle suction. So to your instrument person, you must ask him for a frontal suction. It's like this. It's got one curve like this and another curve like that.
Frontal suction.
Like that. That's the way it is. Okay, that's the frontal suction. Hi. Okay, now we come to what is the intact bulla technique. So in the intact bulla, why do we do an intact bulla technique? To
protect the intertumoral artery.
To protect the anti-ethmoidal artery is not the primary reason why you do an intact bulla technique. Yeah, so I'll tell you. So if the bulla is not reaching the skull base, are you protecting the anti-ethmoidal artery? No. So the primary reason is not the anti-ethmoidal artery. Look, if the bulla is reaching the skull base, then the anti-ethmoidal artery is protected. Okay, and you will go into the frontal sinus without damaging the anti-ethmoidal artery. But if the bulla doesn't reach the skull base, the anti-ethmoidal artery is still exposed to your instruments. You can damage it. But the important thing is that when the bulla is there, the anterior wall of the bulla is a landmark. And if you extrapolate the anterior wall of the bulla upwards, then whatever opens up in front of that anterior wall of the bulla is either the frontal sinus itself or one of the frontal cells. So you can't get lost. Okay, if you open something and you are not sure whether you are in the frontal sinus, just see the anterior wall of the bulla extrapolate it upwards. Okay, this is anterior to that, so it is either the frontal cell or it's a frontal sinus. Whereas if the bulla is taken off, then you can go into the suprabular recess, you can go into the supraorbital cell, or you can go into the frontal sinus. You understand? So then there are multiple openings and you don't know which one it is. So always keep the anterior wall of the bulla intact. If you see an opening which looks like the frontal sinus, that means you're actually in, let's say, in a supraorbital cell. And if you think that you're in the frontal sinus, but that opening is behind the anterior wall of the bulla, then it is not the frontal sinus. The frontal sinus will always open anterior to the anterior wall of the bulla. And therefore you use the anterior wall of the bulla as a landmark where you extrapolate to find that sinus. Is that understood? Yes. That is why primarily you keep the anterior wall of the bulla intact. And of course, if it's reaching the skull base, then it will protect the anterior ethmoidal artery. So this is where you see, that's the bulla, that's a suprabular recess. And this is after the bulla is removed, you can see the frontal sinus and the supraorbital cell. There are two separate openings and they're separated by a partition. We'll come to that. So now the surgical approach to the frontal sinus, like I said, there are two ways of approaching it. One is when there's an agar nasal cell present, and the other is when there's the agar nasal cell is not present. So if you have the agar nasal cell present, then you have what is called the transagar approach. So first thing is you have to expose the front agar nasal cell. So you create what is called an axillary flap, which is what PJ Wormald has talked about. So what you do is you first infiltrate at the axilla of the middle turbinate. And after you do that, you take an incision. You start 7 to 8 millimeters above the axilla of the middle turbinate, which is exactly where a DCR incision will begin. But you don't go all the way up to the inferior turbinate, you stop short halfway. Okay, you stop short halfway. You go all deep, all the way up to the bone, and then you cut halfway there. And then you start lifting up, and as you lift up, you'll see the bone, and very often you will see a suture line. Now you know that I told you yesterday that the agar nasal is the pneumatization of the frontonasal process of the maxilla and the lacrimal bone. So this suture line is actually between the frontonasal process of the maxilla and the lacrimal bone that you see this suture line. Okay, so then you lift up the flap. And then you rotate it and separate it from the thing and tuck it behind the middle turbinate like this. So you tuck it out of the way in the level of the middle turbinate. Okay. So then you have exposed the agar nasal cell here, and then you use with a punch you remove the anterior wall of the agar nasal cell. And after you remove the agar nasal anterior wall, you remove the posterior wall of the agar nasal cell. And as you remove the posterior wall of the agar nasal cell, you will start seeing the frontal recess opened up. You may see some cells. In this case, you can actually see the posterior wall of the frontal sinus. It's convex. And you must remember always to remove the medial wall. Don't leave that medial wall of the agar nasal cell. And that's how you go for a transagar approach for the frontal sinus. Okay, that's the frontal sinus, that's the cell. This is the anterior wall of the bulla. Okay, this is the anterior wall of the bulla. Now, if there's not a very good agar nasal cell, you will follow the uncinate. And like I said, you will stay close to the middle turbinate because this is the uncinate which is reaching the lamina papyracea. So you stay close to the middle turbinate and you move the instrument anteriorly and laterally. And that's the uncinate process being removed. Always submucosal dissection. And when you remove, you should be removing only the bone. And after you remove the uncinate, you can still see this cell over here. This is what I meant, the egg. Okay, so you're staying close to the middle turbinate and you're going above that egg and delivering it out. You're taking it out. And this is again, you see, anterolateral direction. You're breaking the walls of that egg. And as you break it, you will start seeing the frontal sinus coming. This one is either a type 3 or type 4 frontal cell, depending on the vertical height of the frontal sinus. And that's how you will open up that cell and open up the frontal sinus. See this, you do a submucosal dissection and you remove the bone as you do that. Okay, so that's how you will follow the uncinate and go up towards the frontal sinus. Now frontal mucosa. So now whatever we've discussed so far, we're going to put all of it together into a single place, and all those principles we will use for the surgery. So let's watch this. So frontal mucoceles, usually people say, are the easiest to operate, and therefore they are the ones which you should begin attempting first. But remember that all frontal mucoceles don't cause a big bulge in the nasal cavity. They may not be easily seen also. So this is a surgery which we are doing where we are incorporating all the principles we spoke about. So this is the agar nasi, this is the axillary flap we have created, and we lift up that, and then we do take out the anterior wall of the agar nasi cell. And you can see in this case the posterior wall of the agar nasi cell is dehiscent. Anyway, so you remove the entire agar nasi cell anterior wall, the posterior wall is dehiscent, okay? And then in that region, so you're now in the region between in the agar nasi region, so you know that you're already in the frontal recess, you're looking for the mucocele. So you're probing in that area to see, because you can't see any bulge, so you're probing in that area to see whether the mucocele is there. You can't see that, you then palpate over in the thing and look for any movement. You can't see any movement there. So now, oops. You can't see any movement there. So now you're going beyond the agar nasi and removing the upper part of the uncinate. So this is what I said, that sometimes the posterior wall of the agar will be fused with the uncinate, sometimes it won't. Now it's not fused, so you can see the uncinate separately. And you're removing now the upper part of the uncinate. And as you remove the upper part of the uncinate, you're further revealing the rest of the frontal recess behind the, and now you're probing again over there, and as you probe you'll find that at some point the frontal mucocele will open up, okay? And then you drain it. So you press on the eye and you drain it. Now the important thing to remember here is that that's the bulla, that's the anterior wall of the bulla, and that's the frontal sinus opening anterior to the anterior wall of the bulla. Now that you've removed the uncinate, the agar, and you opened up the frontal sinus anterior to the anterior wall of the bulla, now you start removing the bulla. And you remove the anterior wall of the bulla. So this is now we are opening up the bulla, and we are removing the anterior wall of the bulla. And after we remove the anterior wall of the bulla, we start working with a Kuhn's probe in that area. And as you work over there, you'll find, so that's the frontal sinus opening through which the mucocele is draining. The bulla has been removed. And then you probe in that area, and you'll find that there's a partition over there. And when you remove that partition, you will see another cell which looks exactly like the frontal sinus. So that's the frontal sinus opening. That's a cell which looks exactly like the frontal sinus. There's a septa between it, and that's the supraorbital cell. Yeah, so you can see both the frontal sinus and the supraorbital cell. And then you will remove that partition between the two so that the whole thing gets converted into a single space. So always remove the partition between the supraorbital cell and the frontal sinus.
This is a 70 degrees photo?
It's a 70 degree. So that's the frontal sinus and the supraorbital cell. And then don't forget to put the axillary flap back. That you can never forget, because that axillary flap will prevent lateralization of the middle turbinate. That's the frontal lobe. Can you see that? That's the unified frontal sinus and the supraorbital cell. That's the space, and that's where the anti-ethmoidal artery will be. Okay. This is how it looks like post-operatively, and this is the patient pre-op and the patient post-op. Okay. Now I'm going to skip all this, and I'm going to show you So there are two things I want to talk to you about. And one is someone has asked for the draft 3 procedure, so we'll go over that. But before that, just a little, there's a big lecture on complication. I'm not going to go over that just now. Which is the most common complication that occurs in frontal recess surgery? Which of these is the most common?
CSF.
No.
Stenosis.
No. Incomplete surgery. Incomplete surgery is the most common. And what we fear is the anti-ethmoidal artery. Okay? And we fear it because we are worried about blindness. In our mind, what we are worried about is not the... So the artery belongs to the internal carotid system, but it's a very small artery. It's not going to cause hypotension. It's not going to cause bradycardia. It's not going to cause you to run for blood. You're not going to need to transfuse blood in the patient. It's a very small artery. Our problem is that if it retracts into the orbit and it creates a very large hematoma behind, it will rapidly bleed into the orbit. The orbit is a confined space and will bleed behind the eyeball. And it will push the eyeball out. And the optic nerve, which has a slightly tortuous, redundant course, because the eyeball is pushed out, will be stretched. And when the optic nerve gets stretched in an acute way like this, within half an hour to 1.5 hours, you will see vision loss. So that's what is in our mind. Not the artery bleeding itself, but the fact that it can cause stretch on the optic nerve. So that's why we are worried about the anti-ethmoidal artery. We've discussed the anti-ethmoidal artery in great detail. But I want to debunk this myth of the anti-ethmoidal artery. It is not a big deal at all. Suppose you damage it, two things can happen. One, it will bleed and the bleeding will continue. That bleeding, if it continues, it's good news because it's bleeding into the nose, and then you will take some time. There's no hurry. Like I said, the patient is not going to, the BP is not going to drop. Take some time. You make sure that, you put a patty there if required, or you leave it, let it bleed. You can yell at your resident if you want, if you're interested in doing that. And then you can get a bipolar, and you need then another surgeon, and one person will hold the scope, and you will with one hand put a suction on the other side bipolar and close it off. Simple. If it bleeds and stops bleeding, that means it has retracted into the orbit. And if that happens, what is the first thing you will do?
Breaking of lamina.
Pardon?
Means we will break the lamina preparation.
You will break the lamina preparation. Anyone else? Orbital. Same thing. Anything else? The first thing you will do is you will take the palm of your hand, not your fingers, the palm of your hand or your assistant, and press on the eyeball. That is all you will do. And you will press on the eyeball and keep it pressed. What are you doing? You're preventing the eyeball from coming out. See, the whole orbit is solid bone. Okay, the only compressible wall is the globe. So you want to prevent that globe from coming out and the stretch on the optic nerve. That is what you want to prevent. So all you do, if the anti-ethmoidal artery bleeds, is put your hand here and press the globe back. If the globe doesn't come out, then the hematoma will form wherever it forms, but the optic nerve will not stretch. And because the optic nerve will not stretch, they will not get blindness. Is that a difficult thing to do? Till such time you do an orbital decompression. Because when you've done the orbital decompression and you remove the lamina papyracea and you cut the orbital periosteum, you've created a second compressible wall. And so now if you remove the palm of the hand also, the optic nerve will not stretch because the globe will not come out. Whatever pressure is generated will be pressure, whatever stretch will be created or whatever pressure will be generated will be towards the nasal cavity. So till such time that you decompress the orbit and you incise the orbital periosteum, you will just keep the palm of your hand there and prevent the globe from coming out. It is as simple as that. So therefore, the next time you have an orbital or ethmoidal artery bleed, which you will at some point in your career definitely have, that is all you have to do. And then while the assistant is pressing on the globe, all you do is where it bled, you saw where it bled, right? So you start opening the bone from there.
and then you remove the rest. So it's very easy to remove the lamina papyrus. It takes a matter of about 5 minutes. Actually, 5 minutes is a lot, but let's say 5 minutes. And then you take 2 cuts on the orbital peristome up and down. This Narayan will explain to you. The reason I'm talking about the anti-ethmoid artery here is because it's in the frontal recess, and everyone is thinking only about that rather than the frontal recess while operating. That's why I've addressed that. Okay, is that clear? We are now well over time, so now I'm going to stop. There is the only thing that so the rest of the lecture we don't go over. There's only one thing, and that is about, and which will be incomplete if we don't talk about the draft procedures. And these are the, these are the draft 1, 2A, 3, 2B and 3B. We'll talk only about the 3. 3 is from one lamina papyracea to the other lamina papyracea. What you do in a draft is actually remove the frontal beak. When you remove the frontal beak, the entire floor of the frontal sinus is gone on both sides, and both the frontal sinuses are created into a single large cavity into the nose. Please don't do this even under the pretext of a full house fest in basic fest where you're doing it for the first time. Means in primary fest, even if the frontal recess is narrow, if it is mucosa lined, it will heal and it will drain. Normal frontal recesses are very narrow, so they do well. So you don't have to drill out the frontal beak as a primary case at all. Okay. And what I'm going to show you is, so this is the frontal beak that you're going to drill out so that the entire frontal sinus is open. And the landmark that you use, so this is how it should look at the end. This is one frontal sinus, other frontal sinus. This is where the cribriform plate is. This is the anterior table of the frontal bone, and this is one frontal and the other, and all the way from one anti-ethmoidal artery to the other anti-ethmoidal artery, and that's the frontal lobe which is exposed. This is a cadaver. The reason I've taken a cadaver and not showed you, one of the common things you do it is for inverted papillomas and all, is because that the things, the landmarks are destroyed, so you can't see it. I'll just show you very quickly what you do. So the first thing is you open up the frontal recess as much as you can. Okay, in this case it is opened up so that you can see it, but you open up the frontal recess as much as you can. The next thing you do is you take that's the axilla of the middle turbinate. So this is what's called an outside in procedure. So inside out is where you follow the frontal recess upwards and anteriorly and drill out the frontal beak, which is the easier way of doing it, and that is the way you should actually do it. But there is an outside in way of doing it, which is very similar to mastoidectomy, like inside out and outside in. The outside in way is where you actually go through the frontal beak rather than through the frontal recess. So you create this flap. This is anterior to, so this is approximately at the maxillary line. This is where the nasolacrimal duct would be. So at that point, all the way up to the olfactory groove and then coming down onto the septum. And you do this on both sides. And as you elevate this flap, you elevate it till you see the first olfactory. This first thing which you see is actually an artery. Okay, so you open, take off that, and then you can see that's a branch of the anti-ethmoidal artery, and then you see the first olfactory fiber. The reason you need to see the first olfactory fiber is because then you know that the cribriform plate is beginning from there, so you can't operate behind that. So everything that you operate will be anterior to the first olfactory fiber. You do the same thing on the opposite side, and then you take off the upper portion of the septum. So you create a septal window above, in such a way that you can see both middle terminates, and your instrument should go from one nostril to the opposite frontal recess like this on both sides. Okay, like this across, and you can see these are the two first olfactory fibers, and then you start drilling above anterior to this, and as you drill, so you can use, so that's going across there. So this is where the lacrimal system will be on either side. So you start drilling, and as you drill, first you drill laterally, you will see the lacrimal system on both sides. You use them as landmark. So the lateral borders are the lacrimal sac, and the posterior border is the olfactory fibers. And you continue to drill like that. You can use a 15-degree cutting burr. and then as you drill, one sinus will open up, and then you join that to the frontal recess area, and you'll continue to drill till all this is opened up. This is where the anti-ethmoidal artery will be. So you expose it like this, and you continue like that till you remove the interfrontal septum and both the frontal sinus are widely open. Is that clear? So that